This slide presentation will feature information on the leg, ankle, and foot. It will be the presentation which finishes up the lower extremity. The leg includes the tibia and fibula bones. The leg has two joints, the proximal tibiofibular joint. The proximal tibiofibular joint is a synovial joint with a joint capsule, has anterior and posterior thickenings in those capsule, and those are the tibiofibular ligaments, both anterior tibiofibular and posterior tibiofibular ligaments. The distal joint of the leg is the distal tibiofibular joint. Unlike the proximal tibiofibular joint, the distal tibiofibular joint is a fibrous joint or syndesmosis. It has an interosseous ligament associated with it and can be seen here. That interosseous ligament, if sprained, is called a high ankle sprain. So those are the joints associated with the leg. The distal tibia forms a mortise with the trochlea of the talus. This joint that is created is known as the tibio-talar joint or talocrural joint. The motion at the talocrural joint is plantar flexion and dorsiflexion. The talocrural joint is the ankle joint. So the main motions that we see at the ankle joint are plantar flexion and dorsiflexion. A fracture of the medial or lateral malleolus would indeed affect plantar flexion and dorsiflexion. In another slide, we'll be discussing the joints in the foot. The first joint in the foot is the subtalar joint, which is the joint between the talus and calcaneus, or subtalar meaning below the talus. The main motion at the subtalar joint is inversion and eversion. So a malleolar fracture should not affect inversion or eversion. It also stands to reason that a calcaneal fracture would affect inversion-eversion because it affects the foot, but would not affect dorsiflexion and plantar flexion at the ankle. Here we have the bones of the foot. Just like the hand, there are multiple bones involved in the foot, and those multiple bones set up multiple joints and have multiple descriptors. Going through the bones themselves, we have the talus, the calcaneus. Laterally, we have the cuboid. Medially, we have the navicular with its navicular tuberosity. And then distal to the navicular, we have the first or medial cuneiform. In the middle, we have the intermediate or second cuneiform, and then lateral, we have the lateral or third cuneiform. The talus, calcaneus, navicular, cuboid, and medial, intermediate, and lateral cuneiforms make up the tarsal bones. The cuboid and cuneiforms articulate with the metatarsals, and the metatarsals articulate with the phalanx or phalanges. The joints of the foot include the subtalar joint, which is the joint below the talus, or the joint that includes both the talus and calcaneus. Inversion and eversion occurs at this joint. The next joint distal is the joint between the talus and the navicular, as well as the calcaneus and the cuboid. That is the mid-tarsal joint. So the mid-tarsal joint includes the talonavicular joint, and the calcaneocuboid joint. When it comes to remembering which bone goes with which, if you can remember that the C's go together, and there's only 4, the cuboid and calcaneus go together, the other 2 will follow suit, the talus and the navicular. The next joint distal would be the joint between the cuneiforms, cuboid, and metatarsals, which is the tarso-metatarsal joint, or TMT. Distal to the TMT, we have the metatarsophalangeal joint, or the MTP. Here's another picture that's sort of superior, anterior, and inferior. Here is the tibia and fibula articulating with the talus. This is the talocrural joint, or the tibio-talar joint. The main motion at that joint, which we refer to as the mortise of the ankle, is dorsiflexion and plantar flexion. Here is the subtalar joint, the joint between the talus and calcaneus. The major motion there is inversion and eversion. Here is the mid-tarsal joint, which includes the talonavicular and the calcaneocuboid joint. You are also going to see some inversion and eversion at this joint. That will be discussed further when we talk about biomechanics or arthrokinematics of the joints next term. You can see how the navicular will articulate with the first three cuneiforms. The cuboid and cuneiforms will articulate with the metatarsals. So here is where the TMT joint is, the tarso-metatarsal joint. Holding all these joints together are a number of ligaments, most of them extrinsic. There are intertarsal ligaments. Those will not be discussed as part of this course. The majority of ligaments you will be responsible for will be extrinsic ligaments. There are medial collateral ligaments, or tibio-collateral ligaments, as well as a lateral set of ligaments, the lateral collateral or fibulo-collateral. There are also joints on the plantar surface of the foot, as well as an interosseous ligament between the talus and calcaneus. All of these are ligaments you may be responsible for on the exam. Pictured on the left are the medial collateral ligaments, or tibio-collateral ligaments. These are known as the deltoid ligaments. In yellow, we have the anterior tibio-talar and posterior tibio-talar ligaments. In green, we have the tibio-navicular ligament, and in red, we have the tibio-calcaneal ligament. The anterior and posterior tibio-talar, the tibio-navicular, and the tibio-calcaneal ligaments all make up what is known as the deltoid ligament. The deltoid ligament would be affected with an eversion strain, or sprain, excuse me. So an eversion sprain will affect the ligaments that make up the deltoid ligament. The lateral collateral or fibulo-collateral ligaments may be sprained with an inversion sprain. These ligaments include the anterior talofibular ligament in yellow. That is the most sprained ligament in the body. That is right here. That is on your palpation exam. In red, we have the calcaneofibular ligament. And posteriorly, we have the posterior talofibular ligament. So the lateral set, the lateral collateral or fibulo-collateral ligaments include the ATFL, or anterior talofibular ligament, the calcaneofibular ligament that is lateral, and posterior talofibular ligament. Any or all of these may be injured with an inversion sprain of the ankle. As a reminder, on an earlier slide, we discussed two of the joints in the foot, one being the mid-tarsal joint, or the joint between the calcaneocuboid and the talonavicular joints, as well as the tarsometatarsal joint, or TMT, as well as the metatarsal phalangeal joint. Well, these ligaments are stabilized by a number of these joints, are stabilized by a number of plantar ligaments. The first plantar ligament is there in pink. It is the long plantar ligament. It will attach from the calcaneus to the metatarsals. The long plantar ligament stabilizes both the mid-tarsal joint and tarsometatarsal joint. The next ligament is the short plantar ligament. The short plantar ligament is also known as the calcaneocuboid ligament. As you will recall, the calcaneocuboid joint is one of the mid-tarsal joints, so it stands to reason that the short plantar ligament will stabilize the mid-tarsal joint only. Last, in orange, this is the spring ligament. The spring ligament is also known as the calcaneonavicular ligament. The calcaneonavicular ligament stabilizes the calcaneonavicular joint, which again is the mid-tarsal joint. So the spring ligament and short plantar ligament stabilize the mid-tarsal joint or midfoot. The long plantar ligament stabilizes both the mid-tarsal joint or midfoot as well as the tarsometatarsal joint or TMT. The last ligament worth noting is a ligament that runs between the talus and the calcaneus. This is known as the interosseous talocalcaneal ligament. So between the ligaments on the plantar surface of the foot, as well as the ligaments on the medial, lateral, and interosseous ligaments, all of these ligaments stabilize the foot and ankle. The medial collateral or tibiocollateral and lateral collateral or fibulocollateral, as well as the interosseous talocalcaneal ligament, all serve to stabilize the talocrural and subtalar joints. Since no muscles have direct attachment to the talus, these ligaments are important or crucial stabilizers of the proximal foot and ankle. Next, let's discuss the muscles of the leg. The muscles of the leg are divided into compartments. They are compartmentalized by heavy layers of fascia. These layers of fascia that compartmentalize these muscles can be responsible for what's known as compartment syndromes. If there's any sort of infection, inflammation, or inflammatory process going on within those compartments, pressure can build, which will lead to a patient having pain. The leg has three main compartments: an anterior compartment, a lateral compartment, and a posterior compartment. The posterior compartment is further subdivided by a heavy fascia into the superficial and deep space of the posterior compartment. The anterior compartment has 3 or 4 muscles associated with it. First, we have the tibialis anterior that is most medial, hugs the medial part of the tibia. That is the anterior tibialis. Lateral to the anterior tibialis, we have extensor hallucis longus, followed by extensor digitorum longus. Off of the extensor digitorum longus, we have the peroneus or fibularis tertius. The fibularis tertius tendon goes to the lateral aspect of the 5th metatarsal. The muscles in the anterior compartment as a group are innervated by the deep fibular or deep peroneal nerve. Blood supply in the anterior compartment is the anterior tibial artery, and the veins associated with this compartment are the anterior tibial veins. Muscles in this compartment are mainly dorsiflexors of the ankle and extensors of the toes. The tibialis anterior is also capable of inverting the foot, while the peroneus tertius is capable of everting the foot. The lateral compartment consists of 2 muscles, the peroneus longus, which originates on the upper third of the tibia, and the peroneus brevis, which originates on the lower third of the tibia. The nerve that innervates this compartment and the muscles within is the superficial peroneal nerve. Actions of the lateral compartment are plantar flexion and eversion. Blood supply to the lateral compartment comes from the posterior compartment via the fibular or peroneal artery. The peroneal artery branches off from the posterior tibial artery. The posterior compartment has both a superficial and deep space. The superficial space within the posterior compartment is the gastrocnemius, soleus, and plantaris. As a group, these are plantar flexors of the ankle. The deep space, which is often the space involved in compartment syndrome since it is the most quarantined off space based upon the fascial arrangement of those membranes, contains 3 muscles. Centrally and attaching to the interosseous membrane is the tibialis posterior or posterior tibialis. Associated with the fibula is the flexor hallucis longus, and associated with the tibia is the flexor digitorum longus. These are sometimes known as Tom, Dick, and Harry. The main artery to the posterior compartment of the leg is the posterior tibial artery. This runs with the main nerve, which is the tibial nerve. As you recall, the popliteal artery, which was an extension of the femoral artery, the popliteal artery runs in the back of the knee. The popliteal artery will course down the posterior leg where it will branch directly into an anterior tibial that runs anterior to the interosseous membrane into the anterior space, and a posterior tibial artery that will continue coursing down in the deep space posterior to the interosseous membrane. The posterior tibial artery will then give off a fibular or common peroneal or peroneal artery going to the lateral space or lateral compartment. Here's a picture of the continuation of the common peroneal nerve. The common peroneal nerve will wrap around the neck of the fibula. It will come anterior lateral where it will split into a deep peroneal nerve. The deep peroneal nerve is the nerve of the anterior compartment of the leg. And a superficial peroneal nerve. The superficial peroneal nerve is the nerve to the lateral compartment of the leg. So the deep peroneal nerve provides motor innervation to the muscles of the anterior compartment. It will then go into the foot where it terminates as a cutaneous nerve and provides sensation from the web space between the big toe and the second toe. So any sort of entrapment of the deep peroneal nerve, especially at the fibular head, will cause weakness in the muscles of the anterior compartment, which would include the dorsiflexors of the ankle as well as the extensors of the toes, including inversion and eversion of the ankle via the tibialis anterior and peroneus tertius. It then goes on to innervate on the top of the foot the extensor hallucis brevis and the extensor digitorum brevis, which also extend the big toe and the rest of the toes, to then finally become cutaneous in the web space between the big toe and the second toe. The individual muscles of the anterior compartment are seen here. The tibialis anterior, when contracting, dorsiflexes the ankle and inverts the foot. Extensor hallucis longus dorsiflexes the ankle and extends the big toe. Extensor digitorum longus dorsiflexes the ankle and extends the rest of the toes. Peroneus tertius also dorsiflexes the ankle and everts the foot. All of these muscles are innervated by the deep peroneal nerve. Remember our rule for determining muscle actions of these muscles and tendons that cross the ankle. If the tendons are running anterior to the malleoli, which function as pulleys, they will dorsiflex the ankle. If the tendon or the muscles run posterior to the malleoli, they will plantarflex the ankle. If their tendon runs medial, they will invert the foot. If their tendons run lateral, they will evert the foot. The nerve of the posterior compartment, and really the posterior aspect of the lower extremity, minus the short head of the biceps femoris, is the tibial nerve. The tibial nerve will course down. It will branch off the common peroneal and continue as the tibial above the knee. The tibial nerve will then innervate all of the muscles in both the superficial and deep portions of the posterior compartment. The tibial nerve will continue down the posterior compartment until it reaches the medial ankle, where it will divide in the foot as the medial and lateral plantar artery. There are two sensory nerves that branch off of the tibial and common peroneal nerves. The medial sural will branch off the tibial, and the lateral sural will branch off common peroneal. The medial and lateral sural will come together to form sural and provide sensory information from the lateral ankle. Another picture of the sural nerve will be seen on another slide. And look at that, here it is. Here is the sciatic nerve. Here is the sciatic nerve, about a hand's width or so above the popliteal fossa. The sciatic nerve will branch into its components, the common peroneal and tibial. The tibial nerve will course down in that deep portion of the posterior compartment. Here is the medial sural coming off tibial. Here is the lateral sural coming off common peroneal. And there is sural coursing down to provide sensory from the lateral ankle, and really a little bit of the lateral leg as well. Muscles of the posterior compartment include a superficial group, which is here, and a deep group, which is really Tom, Dick, and Harry. All of these muscles, again, are tibial nerve innervated, such that a tibial nerve entrapment or lesion at the knee would create weakness in all that these muscles do. The first muscle under A is the gastrocnemius. It is a flexor of the knee as well as plantar flexor of the ankle. Deep to the gastrocnemius is B, which is the soleus. The soleus is a pure plantar flexor of the ankle, as that is the only joint that it crosses. C, that is the plantaris. The plantaris, as you've seen in lab, is a small muscle with a long tendon. Its ability to produce motion is questionable. Now, in talking about the gastrocnemius and soleus, and really the plantaris, those three muscles all share the Achilles tendon. If the foot is in eversion or inversion, those muscles may have some level of capacity to invert or evert the foot further. But in a purely anatomical position, those muscles, A, B, and C, gastroc, soleus, plantaris, are plantar flexors of the ankle. The deep group includes D, E, and F. D is flexor digitorum longus. E is flexor hallucis longus. And F is posterior tibialis or tibialis posterior. Flexor digitorum longus assists in plantar flexion of the ankle and flexion of the toes. Flexor hallucis longus flexes the ankle and flexes the big toe. Tibialis posterior both plantar flexes the ankle as well as inverts the foot. Again, all 6 of those muscles are innervated by the tibial nerve. The nerve to the lateral compartment is the other branch off of common peroneal, which is the superficial peroneal nerve. Superficial peroneal nerve innervates the 2 muscles that are part of the lateral compartment, the peroneus longus, peroneus brevis. About 2/3 of the way inferior to the split, the superficial peroneal nerve will exit anteriorly from the peroneus brevis, branch into a medial and lateral cutaneous nerve, which provides sensation from the dorsum of the foot. So the superficial peroneal nerve is motor to the lateral components of the lateral compartment, as well as sensory from the entirety of the top of the foot, minus the web space between the big toe and second toe. So damage, compression, or a lesion to the deep peroneal nerve will cause a sensation change between the big toe and the second toe only. Damage to the superficial peroneal nerve will cause sensation change to the entirety of the dorsum of the foot minus the web space. between the big toe and second toe. If the issue or lesion is at the common peroneal nerve, you will have sensory changes both on the dorsum of the foot as well as the web space between the big toe and the second toe. Here are the muscles of that lateral compartment, peroneus longus and peroneus brevis. Peroneus longus, its tendon wraps deep to the plantar surface of the foot to wrap or attach to the base of the metatarsal of the big toe. The peroneus brevis also wraps posterior to the malleoli and attaches distally at the tubercle of the fifth metatarsal. Both of these muscles cause plantar flexion as they are posterior to the lateral malleoli, as well as eversion of the eversion of the foot. So peroneus longus, peroneus brevis, plantar flexion at the ankle, eversion of the foot. Both of these are on your palpation list. So to palpate the tendon of longus, which runs superficial to the belly of brevis, you could palpate the lateral malleolus and come superior and slightly posterior. Resisting of eversion and plantar flexion will cause the tendon to come prominent into your palpating hand. To palpate the peroneus brevis, you would find the fifth metatarsal head come slightly proximal and very slightly superior. You would also plantar flex and evert, resist plantar flexion and eversion, and the tendon of the peroneus brevis, just proximal to that fifth metatarsal head, will become prominent in your palpating hand. Also pictured on this slide is the extensor hallucis brevis and extensor digitorum brevis. The extensor hallucis brevis extends the big toe, while the extensor digitorum brevis participates in extension of the other digits. The extensor hallucis brevis and extensor digitorum brevis are innervated by the same nerve that innervates the extensor hallucis longus and extensor digitorum longus, which is the deep peroneal nerve. It makes sense that muscles that have the same end result action would be innervated by the same nerve for coordination. Blood supply to the posterior compartment comes from the posterior tibial artery. So just as a review, here is the femoral artery. The femoral artery will go posterior as it goes through the adductor hiatus. In the posterior knee, it is known as the popliteal artery. The popliteal artery divides directly into an anterior tibial artery that gets through between the proximal tibia and fibula before the interosseous membrane exists. As that posterior tibial artery comes down, it branches off a fibular or peroneal artery and continues as posterior tibial. The posterior tibial artery will then branch into a lateral and medial plantar artery on the top of the foot. The anterior tibial artery, which divided directly from the popliteal artery, will course through the deep space and in the top of the foot become the dorsalis pedis. The dorsalis pedis will branch off the arcuate and the deep plantar arteries. The arcuate artery, the dorsalis pedis, forms the dorsal arch, and the deep plantar artery also communicates with the lateral plantar artery, thus tying the anterior tibial and posterior tibial arteries together. That brings us to the foot. This is a frontal section of the forefoot, you see the metatarsals bones in this picture. The dorsum of the foot is similar to the dorsum of the hand in that there's not a lot there muscularly. The dorsum of the foot has the tendons of the anterior compartment, extensor digitorum longus, extensor hallucis longus. It has the continuation of the superficial and deep peroneal nerves, the dorsalis pedis and arcuate arteries, as well as the dorsal metatarsal and dorsal digital arteries. The muscles associated with the dorsum of the foot are the extensor hallucis brevis and the extensor digitorum brevis. These structures all contribute to dorsiflexion that's important in foot and toe clearance with gait. So the structures on the top of the foot or dorsum of the foot are mainly the structures responsible for foot and toe clearance with gait. The plantar surface of the foot, much like the palmar surface of the hand, is where the major amount of muscles are located. The plantar muscles in the foot are arranged in layers. These layers of muscles are responsible to maintain the arch. They're responsible for locomotion, and their main responsibility is to prevent hyperextension of the toes during the last part of gait before toe off. These will be covered next semester when we discuss the biomechanics involved in gait. Blood supply to the top of the foot or dorsum of the foot is via the anterior tibial artery. The anterior tibial artery transitions in name in the dorsum of the foot to the dorsalis pedis artery. The dorsalis pedis artery provides blood to the tarsals of the foot. The dorsalis pedis courses between two tendons, the tendon of the extensor hallucis longus and the tendons of the extensor digitorum longus. The dorsalis pedis then will give off an arcuate artery and a deep plantar artery. The arcuate artery, as well as the deep plantar, will give off the dorsal metatarsal arteries, which then transition into dorsal digital arteries. Just like in the hand, the dorsal metatarsal and the dorsal digital arteries run between the metatarsals and between the phalanx or phalanges. The dorsalis pedis artery and the arcuate artery make up the dorsal arch of the foot. The deep plantar artery, which is a branch off of the dorsalis pedis artery, dives deep between the base of the big toe and second toe and connects or anastomosis with the lateral plantar artery. This connection is important as it ties together the blood supply from the anterior and posterior tibial arteries. An injury to the blood supply in the plantar surface of the foot can be substituted for to an extent by the dorsal arteries of the foot in maintaining blood supply to the toes. This goes the same for an injury to the top of the foot, such as dropping a knife onto your foot, a laceration to either the arcuate or dorsalis pedis arteries may cause blood loss from the toes. This blood loss can be lessened by the fact that the deep plantar artery will also branch off blood supply to the toes as well. The plantar arteries will be discussed on a upcoming slide. This brings us to the layers of muscle and fascia on the plantar surface of the foot. Again, the muscles on the plantar surface of the foot are involved in maintaining the arch, locomotion or gait, as well as their most important job, controlling hyperextension of the toes. This would be an eccentric muscle contraction during the last part of gait. If we consider the structures superficially to deep, the first structure we come in contact to is the plantar aponeurosis or plantar fascia. The plantar aponeurosis runs from the calcaneus to all 5 proximal phalanx. Inflammation of this plantar aponeurosis is known as plantar fasciitis. The flattening of the arch because of weak stabilizers of the arch can cause inflammation in this tissue. Constant flattening and plantar fasciitis may even lead to a periosteitis at the calcaneus, or the proximal attachment of the plantar fascia, and that osteitis or periosteitis, inflammation of the periosteum at the heel, may cause the calcaneus to lay down more bone. As you know, the osteogenic cells are just under the periosteum. The calcaneus will want to distribute the heat over a larger surface area, so bone will grow, and those are known as heel spurs. Nerve supply to the plantar surface of the foot and the muscles within is from the tibial nerve. The tibial nerve, which runs with Tom, Dick, and Harry, tibialis posterior, flexor digitorum longus, flexor hallucis longus, will branch on the plantar surface of the foot into the medial and lateral plantar nerves. The medial plantar nerve, which is similar to the median nerve in the hand, innervates 4 muscles. The lateral plantar nerve, similarly to the ulnar nerve, innervates the rest of the muscles in the plantar surface of the foot. Also, like the ulnar nerve in the hand, the lateral plantar nerve has both superficial components as well as deep components. For the sake of exam purposes, you will be responsible for knowing which muscles are medial plantar and which are lateral plantar. For the sake of this video, I will let you know which is superficial and which is deep lateral plantar, but again, for the exam, it's either going to be medial or lateral plantar. Here is the distribution of those nerves. The medial plantar nerve courses along the medial part of the foot, again, and innervates 4 muscles. The lateral plantar nerve courses along the lateral part of the plantar surface of the foot, divides into a superficial and deep component. The muscles innervated by the medial plantar nerve include abductor hallucis, which is really most medial. Lateral to abductor hallucis is flexor digitorum brevis. Lateral to flexor digitorum brevis is the first lumbrical, and lateral to the first lumbrical is the flexor hallucis brevis. The leg model, and even more so the foot model, can help you to understand the innervations of the medial plantar nerve. Again, medial plantar, abductor hallucis, flexor digitorum brevis, first lumbrical, and flexor hallucis brevis. The lateral plantar nerve will then innervate all of the other muscles within the plantar surface of the foot. These include abductor digiti minimi, which is superficial lateral plantar, quadratus plantae, which is superficial lateral plantar, flexor digiti minimi brevis, also superficial lateral plantar, and then the second, third, and fourth lumbrical, which is deep lateral plantar, abductor hallucis, which is deep lateral plantar, and finally the dorsal and palmar interossei, which is also deep lateral plantar. In the next slide, we'll discuss each muscle. All right, so here are the muscles of the plantar surface of the foot. In picture A, we see the first layer. Muscles included in the first layer are the abductor digiti minimi, flexor digitorum brevis, and abductor hallucis brevis. If we remove those muscles, we have the muscles in the second layer. The muscles of the second layer attach to the tendon of the flexor digitorum longus. These include the quadratus plantae as well as the lumbrical muscles. The medial and lateral plantar artery, vein, and nerve are located within the first and second layers within the foot. The third layer of muscles in the foot includes the flexor digiti minimi brevis, the flexor hallucis brevis, as well as the adductor hallucis, which includes both the transverse portion and the oblique portion. Finally, the fourth layer of muscles in the plantar surface of the foot are the dorsal and plantar interossei. In the next slide, we'll go through each muscle. We'll remind you of its nerve innervation. All right, here are those muscles, drawings of those muscles in the plantar surface of the foot. The first layer has 3 muscles. The second layer has 2. The third layer has 3. And the fourth layer has 2. So muscles within the first layer are these first 3. Abductor hallucis, which is medial plantar. Flexor digitorum brevis, which is medial plantar, and abductor digiti minimi, which is lateral plantar. So abductor hallucis, abductor digiti minimi, flexor digitorum brevis are all muscles found in the first layer of the foot. The second layer of the foot contains 2 muscles. Both of those muscles attach either to or from the tendon of the flexor digitorum longus. The first muscle is quadratus plantae, which is lateral plantar, and lumbricals 1, 2, 3, and 4. Lumbrical number 1 is medial plantar. Lumbricals 2, 3, and 4 are lateral plantar. So the second layer of the foot, quadratus plantae, and lumbricals. The third layer of the foot includes 3 muscles. First, we have flexor hallucis brevis, flexor digiti minimi brevis, and the adductor hallucis. The flexor hallucis brevis is medial plantar, and the adductor hallucis and flexor digiti minimi brevis is lateral plantar. Last, we have the fourth layer, which contains the plantar and dorsal interossei. When it comes to the foot, the second digit is considered midline of the foot, such that the plantar interossei are adductors. So the pad and dab mnemonic of the hand holds up in the feet. So the plantar interossei adduct the toes or bring them towards midline. The plantar interossei are all lateral plantar. The dorsal interossei are abductors, meaning that second toe has a medial and lateral muscle for medial and lateral abduction. The dorsal interossei are all lateral plantar nerve. For the exam, please know the innervation to these muscles as well as layer. I may ask which of the following is affected if the third layer of the plantar foot is affected. The answer, quadratus plantae. Third layer, flexor hallucis brevis, adductor hallucis, and flexor digiti minimi. I may say your patient has stepped on a rusty nail, which has gone through the first layer of the foot. What muscles are unaffected? So that would include the muscles in the second, third, and fourth layer. Those are just two examples of how I might ask questions on this information. Last, we have blood supply to the plantar surface of the foot and these muscles. Blood to the plantar surface of the foot comes via the posterior tibial artery. The posterior tibial artery soon splits into the medial plantar artery that courses along the talus, navicular, first metatarsal, and first phalanx on the medial side. The lateral plantar artery arches around and gives off the plantar metatarsal arteries as well as the plantar digital arteries. The deep plantar artery is the artery that connects in with the lateral plantar artery again, creating anastomosis between the anterior and posterior tibial arteries. The plantar arch is then made up from the deep plantar artery and the lateral plantar artery. So again, we have two arches in the foot. We have a dorsal arch that is arcuate artery and dorsalis pedis artery. Then we have a plantar arch, which is made up of the deep plantar artery as well as the lateral plantar artery. This concludes the voiceover PowerPoint for the leg, ankle, foot, as well as the lower extremity.